So now, ladies and gentlemen, dear distinguished speakers, together with my colleague Klaus Lieb, we would like to welcome you to our session today on interdisciplinary approaches to pandemic preparedness. And this session is organized by the Leibniz Lab, Pandemic Preparedness, One Health, One Future. And Klaus Lieb and myself are two representatives of this Leibniz Lab, Pandemic Preparedness. But before continuing with the presentations, I would like to briefly introduce this new instrument at the science policy interface of the Leibniz Association to you. So the Leibniz Lab, can you see the presentation? I can't see it actually. Then, yeah, no. There's our beautiful logo, and now here. The Leibniz Lab Pandemic Preparedness, One Health, One Future joins forces of 41 Leibniz institutes in life sciences, environmental sciences, educational research, and economics across Germany. The inter- and transdisciplinary expertise within the Leibniz Lab is represented by 41 colleagues of the Leibniz institutes. Herein, we focus on respiratory pathogens by combining expertise in respiratory infections, respiratory immunity, and as well as aerosol transmission. And the basic research performed at these Leibniz institutes is then combined with clinical research at the Leibniz Lung Clinic, as well as associated collaborating hospitals focusing on lung disease. And together we form the Leibniz Respiratory Competence Center, which is the largest interdisciplinary network of its kind. And this was urgently needed, given that humankind has experienced 6 pandemics in the last 100 years, and 4 of which were caused by influenza A viruses, and we all experienced the COVID-19 pandemic that was caused by SARS-CoV-2 as a novum. And the next potential pandemic candidate of respiratory origin might be just around the corner. Within the Leibniz Lab, we have 4 focus areas where we aim to prevent pandemics at the source, to reduce long-term disease burden, to design efficient pandemic management, and to enforce pandemic resilient education to the next generation. We will generate roadmaps within the Leibniz Lab to guide through pandemic crisis and communicate to respective stakeholders so that they can implement the knowledge gained into informed action plans. And we have done so successfully in the past. The current influenza surveillance efforts are in part based on so-called host-adaptive signatures in the influenza virus polymerase, which have been identified by my late mentor Hans-Dieter Klenk and myself almost 20 years ago back in Marburg. And today's session actually will focus on the long-term consequences of acute respiratory infections such as influenza and COVID-19, as well as on pandemic management on mental health. Within the Leibniz Lab, we are heavily working on potential pathomechanisms that contribute to long-term consequences of influenza and COVID-19, focusing on autoimmunity, silent virus reservoirs, and fibrosis. In addition to the physiological disease burden, people experienced a considerable mental health burden. During the pandemic, in particular, children suffered from lockdowns, leading to distress and learning delays. Within the Leibniz Lab, we also work on identifying resilience factors to reduce mental health burden in future pandemics and crises. And now I'm very delighted to introduce our speakers today. The first presentation will be given by Dr. Meral Akçay. She is head of the Sanofi Global Influenza Program in Lyon, and she will talk about influenza infections beyond the respiratory tract. The second presentation will be given by Professor Carmen Scheibenbogen. She is the head of the Immune Deficiency Ambulance at the Charité here in Berlin, and she will talk on long COVID, current treatment options, and perspectives for prevention. The third presentation will be given by Dr. Anke Witteveen. She is assistant professor at the Faculty of Clinical Psychology at the University of Amsterdam, and she will talk on mental health challenges and policy directives during pandemics. The fourth presentation will be then given by Dr. Azet Asaminev Alemu. She's assistant professor of psychiatry at the Addis Ababa University in Ethiopia, and she will give her presentation remotely today on Ethiopia's mental health response to COVID-19. And last but not least, the fifth presentation will be given by Dr. Bart Janssens. He is director of the newly established Learning and Education, Director for Learning and Education, of the recently established WHO Academy in Lyon, and he will talk on lifelong learning for a resilient healthcare workforce in preparation for future pandemics. And at the end, we will have time for questions, which will then be collected and discussed jointly in form of a panel discussion led by my colleague Klaus Lieb. And now I'm looking forward to the presentation. So, Mera, it's your turn.
Okay, good. I didn't need my glasses then. Thank you very much, Gülşah, for the presentation, and thanks to all of you for being here this late afternoon at this session. As Gülşah said, today I will try to talk in a nutshell on impact of influenza beyond respiratory tract, mainly focusing on how it impacts the cardiovascular disease outcomes, and also the role of vaccines in reduction of this burden on patients with cardiovascular diseases, and how all that actually ties to the epidemic control and also the pandemic preparedness. So I wanted to, in fact, start with the title of a book that was written by Claude Hanoun. Dr. Claude Hanoun, probably many of you know him. He's the father of influenza research in France. And the title of his book is Our Most Intimate Enemy, Influenza. It's our intimate enemy, and many of you already know that this virus has been with us for hundreds of years, and we have so accustomed to its burden. I kind of think that it's like a, sometimes there's a family violence and we get accustomed to. We are so accustomed to influenza. But as Gülşah said, it also comes around as pandemics and hits us very hard, and we kind of like remember we need to do something about it. And we are still learning about it. We are still learning about what this virus does to us at individual level and also at public health level, and how we can prevent it and how we can still have the better vaccines. So yeah, intimate enemy is still there. And influenza, I think, is kind of like an iceberg. So usually when we talk about influenza, in the medical community or be it in the public, we look at the tip of the iceberg, right? We get sick, we are in the bed for 1 week, we don't take medication, we take medication, so we are done with it in a week. This is general perception. But when you look at the bottom of the iceberg, this is the part that actually makes the ship sink, right? And the biggest burden of influenza actually lies here. And as you can see, it leads to pneumonia. Of course, it's a respiratory infection, but beyond that, it leads to triggers heart attacks, stroke, exacerbates all the chronic conditions, and the majority of the personal and public health burden actually lies there. And this part actually has been recognized by the small influenza community for a long time. But unfortunately, the bigger medical community and the policymakers are now realizing the impact of influenza within this frame after the COVID-19 pandemic. So for me, sometimes I really resent, because I've been an influenza expert for the past 15 years, and in my academic years also we focused on this a lot. We could not change the minds of people, but unfortunately we learned this with the pandemic. And I also wanted to bring to you the leading causes of death published by WHO. And as you can see, the heart diseases, the cardiovascular diseases is sitting on the top. And when you look at the data, in fact, influenza impacts the outcomes at least of 7 out of these 10 leading causes of that globally. And that's why today I wanted to talk a little bit deep into how influenza is impacting the cardiovascular disease outcomes. In fact, the association between influenza seasons and increased incidence of cardiac events has been known since the beginning of the century. As you can see, the publication comes from 1932. And you can see that big sharp increase there right here. Of course, it coincides with the 1918 pandemic. And then there are documentation about how the cardiovascular diseases or incidence was increasing. But these were observational studies, and there were many questions about this topic. So yeah, maybe it's winter, maybe there are other things that are associated with it, maybe it's other things, it's not influenza. Since 1932, of course, there has been many more publications, observational studies, and all that. But lately, there was a development of a methodology called a self-controlled case series study design, which is a very nice study design, actually. It tries to reduce the bias, and it tries to really look at the actual impact of influenza and cardiac outcomes. So basically what you do is you take this database and in the hospitals, and you look at the patients who were hospitalized with a myocardial infarction and who also had lab-confirmed influenza diagnosis. And then you look at that, and then you take the diagnosis of influenza as the day one as your index day, and then you look at, you set a period there. Let me put it that maybe. So the day of the diagnosis, 1 month after, so that's your risk period, and then 1 year before and 1 year after is your control period. And then you look at to see whether influenza increased the risk of having your first myocardial infarction or not. And again, because each patient is a case and also the control, you're kind of reducing the biases of looking at different patients for the outcomes. And using this methodology, the first study was published in 1918 from Canada by Kwong et al. So they looked at this database of patients. The ages started from 35, as you can see, it says there. But majority of these patients actually were older than 50 years old. So there were a couple of younger people, but majority of them older. And if you look at the graph there, you see that the risk of influenza risk of myocardial infarction within 1 week after influenza lab-confirmed influenza infection increases about, I guess you can see it here. I don't have the pointer. They said it's not working. So about 6 times. Of course, and you can see RSV and other viruses also do increase the risk. But however, many of the studies that actually have been published, they put the influenza as the queen of these viruses. So somehow there are some hypotheses why influenza might be increasing the risk, but they are just hypotheses that they actually need to be proven, but good hypotheses, I can actually say. And then another study actually came from Denmark. And they were also using the same methodology, and they were also able to demonstrate that influenza increases the risk of first myocardial infarction in people, and that in fact that is the higher risk is within the 3 days after the laboratory confirmed influenza, and they said that it's the risk is about 17%. And there are other studies. There was another study that came from Scotland, and they said, okay, it's 10 times. So basically, these studies are telling us whether 5 times, 3 times, 6 times, 10 times, there is a risk there if you have an influenza infection that increases the risk of having your first myocardial infarction. And okay, so if influenza is impacting the cardiovascular disease outcomes, then what are the vaccines doing? Are the vaccines any good or not? And the cardiology societies and cardiologists were much interested on this topic. So this led to development of some studies, randomized controlled trials. 2 of them were conducted in the beginning of the 2000s. There were small-scale studies, randomized controlled trials, but very small-scale studies. They were kind of giving us an idea. Oh, yes, yes, there is a benefit there. But then the cardiology community was not convinced because they wanted to have large studies, they wanted to have the studies with the statistical power, and then there was another study conducted by Ole Flaubert and colleagues that lasted about 3 years globally in 8 countries around the globe. I'm not going to go into details. If you want to read, you can read the paper. But this was a double-blind, randomized controlled trial. And here is their results, basically. So the primary endpoints of composite outcomes of all cause of death, myocardial infarction, and stent thrombosis. Influenza vaccines were 28% effective in reduction. And this was statistically significant. But what I think is most important is the secondary endpoints, in fact. So influenza vaccines were 41% effective in reduction of the all-cause death, and again, similarly effective in reduction of cardiovascular death. But then for the myocardial infarction, it was effective by 16%. But however, because of the low number of the events, this was not statistically significant. But overall, when you look at influenza vaccines, are actually having impact in the reduction of this burden. And of course, cardiology community was very excited about these results, and they actually have published a lot of reviews on these studies. There has been a lot of observational studies, of course, in between. So I'm just talking about the randomized controlled trials because, as you know, to be able to establish the causal relationship, we have to have the randomized controlled trials. Then you can actually support them with your observational studies or real-world evidence. So when you look at this graph here, I think it's very important, and this was actually presented by the cardiologist and it's been published as a secondary prevention measure of the cardiac outcomes. There are commonly used medications, and statins is one of them, as you can see. So here in the in this line, you've got the statins, and here you've got the influenza, and you can see that the impact of influenza in reduction of the cardiovascular death is huge. Of course, keep in mind that we're talking about influenza-triggered cardiac events. We're not talking about any cardiac events that is related to the hypertension or other effects. So now, we know that these vaccines are impacting, and how does that really tie to our goals of prevention of epidemics and pandemics, and what do we expect from the vaccines now? And we learned also with the COVID pandemic that you may not be able to prevent transmission with the vaccine. You may not be able to prevent mild infection with the vaccines, but the vaccines might actually bring you much deeper benefit than we are experiencing. So then what do? Do we measure the vaccine effect or evaluate vaccine performance by their ability to prevent transmission, lab-confirmed infection, severe respiratory disease such as pneumonia, or all other hospitalization, all-cause hospitalizations, or in reduction of hospitalizations due to all chronic diseases? And the other question is, of course, since this morning we hear about trust, and we're talking about trust and all that. So to build the trust, I think we need science, and we need good science. And anybody, I work for Sanofi, so, and you might think I might be biased, but I'm not biased, certainly, because I used to be an influenza expert, and I also worked in public health. So my heart is really there. So when we are generating data on these vaccines to understand their performance, the methodology is very important. And this is the responsibility of everybody, scientists, the manufacturers, the regulatory bodies, to make sure that the data that is generated is trustworthy. And how do we really do that? We have to start with the randomized controlled trials to prove that the result is because of this vaccine. And then you can actually, of course, decorate that with your observational studies, and we need to improve the observational studies. And we know if you, in the absence of randomized controlled trials or any better trial that is out there, we can fall into the trap that we fell into during the COVID-19 pandemic, where the observational studies suggested that the hydroxychloroquines and ivermectins, they are good for our patients, but then in the end, the randomized controlled trials proved that that was not the case, and in fact, you could actually harm your patients. So this is, I think, very important. The study quality of the science, everybody needs that. The manufacturers need that, and the whole world needs that for the trust in science and in also the manufacturers. And with that, I wanted to tie this into a little bit of like how all of these tie into the pandemics and the epidemics. So we know that pandemics come in a short period of time and hit us, and they are devastating. And personally, myself, I've suffered a lot because I lost many people dear to me during the COVID-19 pandemic. But when you look at the data, right, during the inter-pandemic times, as Gülşah said, the influenza is the queen of the pandemics, queen virus of the pandemics, and we will probably have another pandemic. We don't know when, but we will have it. But in the inter-pandemic area, you have much more burden than during a pandemic itself.
1 minute.
1 minute. I'm done. I knew I was going to go quick. So we need to then do something during the interpandemic seasons so that we can actually be prepared for the pandemics, right? We should not forget about that. Pandemic preparedness basically comes with the epidemic preparedness. If we're prepared well during the epidemics, if you establish a very good surveillance system, that is a must, and I have done that personally. And if you don't have that in the countries, you don't know what's happening in your countries. The surveillance is a must, a quality surveillance is a must. And then, if you have the vaccination programs, establishing good vaccination centers and who's going to do what is very important. And we actually experienced that during the COVID-19 pandemic, right? The surveillance that was established for influenza was used for COVID, and also the vaccination practices also. So we have to be prepared during the epidemics so that we can be better prepared for the pandemics. So thank you very much. I guess I'm on time, right? Yeah. Thanks a lot.
So we directly move on with Kram.
So, hello everybody, and thank you very much for including this very important topic. So I'm going to talk about long COVID, a global challenge and perspectives for prevention. I'm a clinical immunologist, and I work at Charité in networks treating and researching on post-infectious diseases and long COVID. So during the next 13 minutes, I'm going to talk about the challenge and the perspective for prevention. And here you see my disclosures of industrial relations. So long COVID is actually not a completely new disease, but it belongs to this large group of post-acute infectious syndrome. Many of them we have known for decades. I listed here some post-polio syndrome, post-Lyme syndrome, EBV chronic fatigue, and there are many others. And long COVID is, of course, most relevant at the moment due to the high numbers of sufferers. We know that long COVID comes along with many different symptoms, with fatigue among the most relevant for many patients. And we have so far several definitions of long COVID, which makes research more complicated. The definitions include different subgroups of patients. So some include also patients who have diseases triggered by COVID, which belong to well-known diseases or organ manifestations. And the more stricter definitions just focus on those suffering from various symptoms or syndrome, which is more which fits more to the term of the post-COVID syndrome. So is long COVID a pandemic challenge? The answer is yes, and this is represented by the high number of patients. So this is from meta-analysis just recently published, and with a cumulative estimated number of 400 million long COVID patients worldwide. That is approximately 5% of the world population. And with this comes a high also economic and social burden. There are many of these people who are so sick that they are impaired in workability, and the most severely ill people are often bedridden. This results also in a decline of the global gross domestic product between 0.5 and over 2%, as you see here in this table. So what is worrisome too is that long COVID is not over. It's still on a stable rate of numbers of people suffering worldwide, and we have learned from several recent studies that the risk of long COVID actually increases with every infection, as you see here on this figure. So after the first infection here, we have a number of 1.3%. That is from a patient base, so why it increases to 3.7% after the second infection and to 6.5% after the third infection. We know little about the problem of long COVID in the low-income nations, but probably it's even a higher problem there due to the low vaccine prevalence in these countries. We have little information about prevalence at the moment and risk factors there. And of course, we have in many regions lack of care structures, few physicians acknowledge even that long COVID exists. This is a study from the Lancet Global Health recently published, and it's again a meta-analysis of the few studies analyzing prevalence and risk factors for long COVID in Africa. And here you see this huge range of numbers ranging from 2% to 86%. However, what you see too is that on average, these studies report on an incidence of 50% of long COVID in these African studies. So, and what I want to stress again, that we do also have a high risk of other post-infectious syndromes due to many other viral infections. And that is also true during the pandemic. What you see here on the left side are the probabilities of getting long COVID during the different variant periods, so from the wild type to the Omicron. And you see that we have now decreasing risks, but if you look in the middle figure, that is the risk to develop post-infectious syndrome triggered by other viral infections. And as you see, now the risk is already as high as the one to get long COVID from a COVID infection again. And then I want to point to ME/CFS, myalgic encephalomyelitis chronic fatigue syndrome, which is the most severe form of a post-infectious syndrome and also of long COVID. It's a debilitating chronic disease, and it's triggered by numerous viruses. SARS-CoV-2 is currently still the most frequent one, but it's also triggered by influenza, by EBV, by enteroviruses, and many others. Its characteristic is the severe exertional intolerance, meaning that daily activities can result in worsening of all symptoms called post-exertional malaise, and it usually goes along with severe neurocognitive impairment called brain fog, with pain and vascular problems or aesthetic intolerance. It's estimated to be 10 to 30% of long COVID cases. It has been known for long, so the WHO classified it as a neurological disease. Current numbers from USA are more than 1% sufferers of the total population, and most of them are severely impaired. More than 50% are unable to work, 25% are severely impaired, and a subset is bedbound. It affects predominantly middle-aged females, but also adolescents and even children. And there is still no specific treatment for this terrible disease, and few of these patients are with adequate care. So coming to prevention of COVID is of course prevention of long COVID, and we do have data that vaccination also prevents from long COVID. Unfortunately, and that's what we learned, the prevention is not 100%. As you see here from this retrospective match cohort study, we have differences in the diseases and symptoms which are prevented by vaccination. So looking on the top, actually mental disorders triggered by COVID are not prevented at all by vaccination, whereas on the bottom, as you see, the so-called syndromes are most effectively prevented by approximately 50% by vaccination. So we need further strategies to lower the risk of long COVID and of course other post-infectious syndromes. And those are either antiviral treatments or anti-inflammatory treatments. And I'm going to show the few data we have from studies at the moment. This is a retrospective study analyzing the effect of Paxlovid or nirmatrelvir on the risk of developing long or post-COVID. And in this study, there were almost 300,000 people analyzed, and those 35,000 who got treatment with Paxlovid, which was given within the first 5 days of the acute phase, had a reduced risk of developing post-COVID, but that was only 0.74, and it was similar in those who were vaccinated or with primary or reinfection. We have one very interesting prospective controlled trial. This was performed very early in the pandemic, starting in December 2020 already. And here patients received, when they had COVID, within 7 days of symptom onset, 3 different drugs. One was metformin. They got it for 14 days. And here you see the results comparing metformin intake with the placebo control, taking placebo drug. This was a large trial with people in the middle age. Median was 45 years. They were overweighted, so the body mass index on average was 29. More than half were female. And as you see on the right side, the risk of developing long COVID was diminished in those taking metformin. If they started early on, they had a risk of only 37% to develop long COVID. If they took it later, the risk was still diminished to 66%. And in this treatment trial, ivermectin and fluvoxamine were tested as well and had no effect. And then there is another very recent study analyzing the effect, and that's an interesting finding showing that metformin is indeed also able to reduce the viral load. That is shown here. The blue curve is metformin, the pink placebo. And the effect is probably not only in reducing a viral load, but metformin has more effects. It can also reduce oxidative stress and inflammation. And we have good evidence now that overreactive immunity, inflammation, and probably also autoimmunity is one of the main mechanisms of long COVID. So this finding is from the first promising studies in long COVID, and it's especially important for those having risk factors. Many of them we know already, the female sex, but also having a medical comorbidity, several other, we know also genetic risk factors now. So coming to the end, yes, long COVID is a global health, social and economic challenge. The global cumulative incidence at the moment is estimated to be 3 to 5%. We have learned that vaccination lowers the risk of long COVID, and we have first promising data for second prevention efficacy with metformin. And if you're interested in this ME/CFS disease, I invite you to join our third International ME/CFS conference at Charité in May next year. Thank you.
Thank you. Exact in time. Thank you.
Yes. Good afternoon, everyone. It's a pleasure and an honor to tell you today something also from another perspective than, of course, respiratory and cardiovascular backgrounds, about mental health and pandemic preparedness in the mental health care systems across several European countries. And I would like to do that by explaining something and telling you something about our findings in our EU-funded project Respond. I'm a clinical psychologist and also epidemiologist, and I hope to show you some findings that can also and need to be taken into account in terms of pandemic preparedness. This is an overview of our entire project. I will not focus on so many details, and that's not possible within 30 minutes, but I do want to give you some takeaways based on our findings over the last couple of years. We started in December 2020 and ended last June our project, and we are still working on it in terms of publishing and working with the data. First of all, we looked into identifying high-risk groups during the pandemic in terms of mental health and also in terms of resilience and well-being, and also what are the key determinants and also social determinants of the mental health deterioration, or the other side of it, the resilience, for example. Second goal was to look into the responsiveness of mental health care systems across several European countries. And colleagues from London and Louvain in Belgium, they looked into many qualitative data from many countries. I will show you in a bit. And the third aim was to test two interventions developed by the WHO, which are highly scalable for people with for vulnerable groups and also for frontline healthcare workers. At least we focused on those groups and tested those interventions in a stepped care format, and I will also explain that to you. Why did we do this entire project together with 14 partners? They are all mentioned here below. We wanted to have something in our hands to be able, for future pandemics, to scale up certain programs and particularly the psychosocial interventions, and to be able to address in the future with future flare-ups of pandemics or even beyond that. We are also working with the same programs in war and conflict situations to address the mental health consequences and get these programs to the people really in need of it while there are low resources. Well, first I want to dive into a little bit into all the findings based on all the work of partners in terms of identifying these high-risk groups for these adverse mental health consequences. What we did, we also looked at multiple meta-analysis available during the time of COVID and produced during the times of COVID and afterwards, and based an umbrella review on that. And what we can say based on that information is actually that many or most people are resilient, but there was across all studies collected and analyzed, and also quantitatively, a small significant increase in mental health problems. This is not surprising, of course, and particularly in depression during severe restrictions in terms of public health. What did we do within Respond? We used data from many of the partners mentioned in the previous slide. They had data, often longitudinal, or they were all longitudinal data sets during the pandemic, so multiple assessments, and some even had pre-pandemic assessments, and particularly those are absolutely very important and informative. What we did during Respond, we harmonized these data sets into one comprehensive data set, the co-Respond data set, and we are still working on the output based on that harmonized data sets. What's also done by several partners, by Spain, by Sweden, Italy, they use their health registry data to capture patterns in that data in terms of mental health during the COVID-19 pandemic compared to pre-pandemic. And based on all this data, what did we find? Not surprising, because it's, I think, all out in the open, that younger people, students, and not not particularly the older people, but particularly young people and women were more vulnerable for mental health problems. And then we talk about anxiety, depression, symptoms of post-traumatic stress disorder, so more the common mental disorders. But also more specific groups like people with a migrant background or refugee background. In Sweden, they looked into the health registers and analyzed the data and saw that during the pandemic there was increased mental health care utilization in this group. Furthermore, there was also studies, a number of studies on healthcare workers in our project. For example, recently, colleagues of ours, they published on particularly several assessments during the pandemic in healthcare workers and showed that particularly women in this working in this field during the pandemic were vulnerable. And this is, of course, not surprising based on the other factors or the other groups more vulnerable during the pandemic. And there are several explanations to give for that, of course. It's also important to note that it's not all consistent. For example, in people with pre-existing mental disorders, we would have expected them to deteriorate more during the pandemic, but this was not robustly found based on the data, based on healthcare data. For example, in Sweden, they looked particularly at suicide rates and suicide attempts, and both were either decreased or stable. And in Italy, a same pattern was found. At the same time, it's important to note that there was a significant reduction in getting access to the mental health care in this group. So we have to bear that in mind. And also have to bear in mind for people with pre-existing mental disorders that they more often died from COVID-19 infections than other groups. This was also based on health registry data. Then, of course, we are also still looking into the determinants, the social determinants, for example, of being more affected in terms of mental health during the pandemic. And one factor clearly shown by a French study was that being unemployed or having financial instabilities, is really a factor to take into account. And we see that in previous pandemics over the last century as well, that other turmoil in societal crisis that affects mental health. So it's maybe not surprising, but still. We also look into psychological factors, people with higher levels of neuroticism, catastrophizing. This is all giving a higher risk of more mental health symptoms during the pandemic. Then I just shortly want to capture something from the work of my colleagues from the London School of Economics and from the University of Louvain in Belgium. What they did is, amongst other things, they did a discrete choice experiment. And in that, they compared what policymakers, but also the general population, prioritize when making decisions regarding how to tackle COVID-19. And in what way did they take into account the mental health of people? And were there differences? So there were different trade-offs to make in terms of the hospitalization rates, the percentage of increase of distress, how many jobs lost. And all these things were presented to these people, and they made trade-offs mostly between the level of psychological distress in the population or the risk of hospitalization. The key finding is that stakeholders, so policymakers, they prioritized mental health more than the general population and were more critical of suppression policies affecting mental health, while the general population prioritized mobility over mental health. Then looking into the third aim of our project is based on the fact that the access to, and I'm going back, the access to in-person mental health care was, of course, very much decreased and limited during the pandemic. So we saw an increase of remote delivery in terms of video conferencing of sessions, psychiatric sessions, for example, or clinical psychology. And this is, of course, also has been a chance actually to develop this part more. And it is interesting that in our project we tested 2 remotely delivered interventions. They were developed by the WHO. And the core features of both interventions are that they are easily culturally, or easily you have to do work for that, culturally adapt and also linguistically. But they also focus on a broad number of symptoms: anxiety, depression, PTSD symptoms. And at the same time, they are delivered by, and we call that task sharing, by peer helpers. So people from their own community are helping people from their community. So this is in terms of resources, but also in terms of effectiveness, we think very important. Well, we did it in several countries: Spain, Italy, France, and also in the Netherlands. And since I'm from the Netherlands, I will focus a little bit more on the labor migrants in the Netherlands. But for all trials in all 4 countries, we had the same format, the same design of an RCT, with the intervention being a stepped care intervention. A first step was that people with an elevated level of distress, they received 5 weekly modules of acceptance and commitment therapy through a mobile app, and they got as support from a helper from their own community, or from, in this case, labor migrants. And afterwards, we tested them and assessed them again, and if they still had increased distress levels, they stepped up to problem management plus, which is the cognitive behavioral approach in 5 face-to-face sessions of an hour, also again with trained and supervised peer helpers. And we did this in labor migrants from Poland, because there's the largest group in the Netherlands, and they have multiple difficulties actually in housing, health insurance issues, and in demanding, sometimes dangerous jobs. We used the study design of an RCT, which is familiar maybe to most people here, into 2 groups by chance, and looked at whether or not the intervention arm was superior to care as usual. We were able to have roughly 80% going through the mobile app sessions. 90%, which is quite high, of the labor migrants still had symptoms after the first step. And they stepped up to PM+, to the face-to-face online sessions. And most of them, 75%, they finished those sessions. What did they look like at baseline? In terms of symptoms, they had a high to moderate level of symptoms in terms of depression and anxiety. They were more often a female, much more often actually, 75% in the Netherlands at least, and had quite a traumatic event exposure over the last 2 weeks. Then, of course, the most interesting part, I think, is to see whether this works or not, at least in these labor migrants. And what we see here is the yellow line is the intervention arm. We see, except of course for baseline, a larger decrease of symptoms at T2, which means after the mobile app, but also after the face-to-face interventions even more. And then after 2 months of finishing, you see also still some progress and a reduction of symptoms in our labor migrants. We did the same in other countries, in a little bit different population, but also migrants, for example, in Italy, in refugees and migrants.
Time is off.
Time is off, okay. And in France, we saw the same. And this is my last slide. The conclusions based on all our work, and this is all in a snapshot, in a nutshell, actually, to facilitate effective communication about mental health impacts, to make sure that there are multiple credible indicators of mental health and that they are assessed throughout the pandemic, but also before the pandemic. So, yeah, these health registers gave us a lot of information. And then the final takeaways are that effective strategies or interventions need to be incorporated in these responses in terms of pandemic preparedness and beyond that, also societal crisis and war situations, for example. Thank you very much also from my colleagues in this project. Thank you for your attention.
No, you don't know. You don't need it.
Oh.
Don't need it. She makes it online already. Great, thank you.
Okay.
I'll
Good
check.
afternoon, everyone.
Yeah. It's good.
Good afternoon, everyone. I hope you can all hear me. Thank you for the invitation to present on Ethiopia's mental health response to COVID-19 with a focus on what we've learned from the COVID pandemic. I'll be presenting based on my experiences and working in the Professional Advisory Council during the COVID pandemic, during the first year, as well as some of the published studies we had with my colleagues. So to give you some context about Ethiopia, so Ethiopia is found at the Horn of Africa. And this is where WHO Atlas report from 2017 that shows how many mental health professionals there are over in a 100,000 population. This is just 2 years before the pandemic hit. So you can see how much restrictions we had regarding the professionals who can provide mental health care. This also means that we didn't have enough mental health care facilities for 120 million people who reside in the country. And this also affects access to medications. And what this meant is that people relied more on traditional and religious services. And also they all relied on the support of families and traditional social care institutions. So when the pandemic hit in March 2020, this pre-existing challenges were accentuated. So one of the problems that were accentuated was the social vulnerability of people with pre-existing mental health conditions and also people who are affected by the COVID pandemic. For example, the traditional and religious care institutions that I mentioned earlier were not as active during the early months of the pandemic because they had restrictions and they wanted to reduce crowding in their institutions. So they were not accepting new patients and they were also discharging some of them. So this meant that there was an increase in homelessness with mental health conditions, and they didn't receive targeted infection prevention education. So this meant that they were not aligning with the mask mandate that was in place in our country, which made them vulnerable to be in jail due to not knowing what to do. And also those people who had some symptoms, respiratory symptoms, were facing double the stigma because of their symptoms and as well as the mental health symptoms. And an additional burden we had at this time is people who have migrated from Ethiopia to other countries. They were being deported because of the COVID pandemic, and there was a mass deportation. And these people were being put into quarantine centers. And these people had mental health needs related to their experiences of migration, and as well as some of them were imprisoned. So there was a lot happening at the same time. Another aspect of the challenge was also the disruption of the little available mental health services. this services, mental health services, was majority of the inpatient centers were reduced or closed so that they can serve for COVID-19 related services. A notable one is the closure of a 150 inpatient bed unit in one hospital just to be repurposed into a COVID-19 service. And the ones that continued to provide inpatient services, they had to reduce family visitations, group activities, electroconvulsive therapy, and any psychological intervention. So the quality of care was also reduced. There were also associated human rights issues, and these were mainly because of transportation restrictions that existed. People could not really go to their follow-ups. And this meant that they stayed at home and they faced restraints at home or other social institutions. And people who were infected with the virus also didn't have enough access to physical care services. Just to give you an idea of what it looked like in the early phases of the pandemic, this is data from Emmanuel Specialized Mental Hospital. So this is a purely psychiatric hospital. And you can see how the inpatient service utilization dropped starting from March of 2020, started to pick up in the later months. So what this shows you is that in the beginning phases of the pandemic, there was very low preparation that went into the pandemic preparedness regarding mental health services. So when we look at the initiatives to mitigate the challenges, so later in the process, the Professional Advisory Council that we are part of advocated for the inclusion of mental health in the planning and response of COVID-19 pandemic in the country, and this led to capacity building trainings for frontline healthcare professionals, which included trainings on psychological first aid, trauma-informed care, and also used MHGAP. In addition to that, we developed multidisciplinary volunteer-based mental health and psychosocial teams, which included professional social workers, psychiatry nurses, and psychologists who would provide services on a part-time basis in quarantine and isolation centers. So this alleviated some of the problems. The other things that were being done in the country is some private institutions started online psychiatric consultations. One of the COVID treatment centers built a room which has a glass partition so that they can maintain face-to-face interaction while also maintaining the physical distancing requirements for people who are infected with the virus. And because the people were having restrictions of transportation and they couldn't move from one place to another to receive mental health care services, many hospitals shortened the frequency of outpatient visits and they prescribed medications in bulk so that people wouldn't run out of medications. And when possible and when available, people were being referred back to local mental health services. This is also similar to some of the experiences that we have seen in other low and middle income countries. This data is from a recent print we published that looked at 7 low and middle income countries, which are Nigeria, South Africa, Sri Lanka, Georgia, Ukraine, and one other I'm forgetting. So some of the approaches that we've seen as initiatives is using digital and phone services to fill the gap in the services, to provide information, to provide psychiatric consultation, to monitor patients who are on treatment, to provide psychological therapies, as well as to train and mentor health professionals. Another aspect of the initiatives is in some places, mental health was seen as an essential service, and mental health was integrated into the primary healthcare, which was very helpful. And countries like Ukraine used mobile mental health teams to check on patients and deliver medications. And there was also positive initiatives regarding coordination of care between mental health services and physical health services, and also coordination with non-clinical social services, as well as interaction between primary and specialized mental health centers. So what can we learn from all this experience? So one of the things we have seen is that there is a significant problem regarding structural stigma. So in the initial phases of the COVID pandemic response, mental health was not part of the planning. Not only that, it was considered to be a low priority area. And it was only after incidents or reports that people were attempting suicide in quarantine or isolation centers, or people were distressed after being admitted for COVID treatment. And this kind of reports are what made it become more mainstream and more considered as an essential service. I think an early recognition that there is a structural stigma that we need to fight is, I think, important in future preparedness planning. Another thing we have also seen in our country, especially, is that because we didn't have a mental health act, we didn't necessarily plan for the possible human rights problems that we would face during this process. So integrating this is also part of our planning for the future. Another thing we've learned is that because we didn't have enough mental health services, we do not have the means to reach people in remote areas who needed mental health services to prevent relapse for people who are already on treatment and to be accessible in general. So this is also consistent with our mental health strategy to integrate mental health services within general health systems. This particular part is going to need a large investment to train mental health professionals, to also train other health professionals for providing primary care services for people. This is also helpful so that we can pick physical health challenges of people with mental health conditions so that they can get appropriate physical health care. Another good thing that we've noticed during the COVID is that we are more and more comfortable using online and other digital technologies because of the restrictions that were in place. This is also part of the reason why I'm presenting online today, because we're more used to using online means. And even though there are still issues of connectivity and access to internet in most parts of the country, I think that we can still use this opportunity to interconnect different services, primary care to specialized centers, among different disciplines, to share information, to mentor and train different health professionals, and also improve on our data capturing by improving our key indicators that are needed. So in conclusion, even though there was a lack of preparation that we noticed in the beginning, there was some improvements noted during the response. But as long as that we work on strengthening the existing mental health services, I think we can be better prepared for future pandemics. Thank you.
You are fine. Just take your time. Take your time.
Okay.
2 minutes. No, we are good in time, so take your time.
Yes, good afternoon, and thanks to Gülsa of the Leibniz Lab to inviting me to this really, truly, and nicely interdisciplinary panel. So I will talk a little bit about learning for healthcare workers, and specifically a small spotlight on the work of the recently established WHO Academy. This one, yes. So if the world now for once and for all I learned one thing is how important healthcare workers are in in any health care system and how painful the consequences are if we neglect them. A motivated, empowered health workforce that is truly connected and to skills and competences that are up to date is absolutely essential for any healthcare system. I've done a little bit of research into all the reports from lessons from the pandemic. And around the healthcare workforce and its learning, 5 themes always come back. And this is a bit what we've seen. First of all, without a surprise, digital learning. Healthcare workers need on time and on the right format, the right information. This could be from micro-learnings, job aids, to more longer online courses or blended courses with a nicely motivating credentialing. Secondly, healthcare work is by nature teamwork, while not always teams function very well. So really on the intersection between the different groups, people need to learn as teams, need to work as teams, and then only people can be, as groups, better prepared for any new pandemic. Without surprise, of course, also training around emergency preparedness. This is, on one side, a lot of universal or generic skills that are useful in any kind of health emergency, like connecting to communities, integrating mental health in all aspects of healthcare, and specific skills like vaccinations. All these you can prepare for ahead, while then at the right time you can readapt specific new learnings to the specific problem that the world has encountered. And it's very important to do that at the 3 levels, globally, in regions and in countries. Continuous professional development. I think in the global north there are a couple of countries that spearheaded this like 20, 30 years ago. A lot of countries struggle to have a very performant continuous professional development system for their countries. And this is a fundamental basis also for the next pandemic. If we could already be assured that IPC standards, good vital sign control for severe patients is already established, we would already feel more trustful for services to take on patients. And then connecting all of that is that the power of simulation-based learning works on group learning, works on emergencies, works on continuous professional development. So it was only timely that under the leadership of our General Director, the WHO took the initiative to launch its academy as a real symbol, a symbol that once and for all the WHO is going to take a lot of importance to help the healthcare workers. And looking at 3 levels strategically, to have skills and competences constructed that are directly linked to creating an impact for healthcare workers and healthcare systems for patients. Centrally, all of that is the whole strategy and theory of lifelong learning, and the goal is that we create an academy that can produce lots of learning material connecting to many healthcare workers, specifically where the needs are the biggest. Looking at our strategy, we could actually explain that the WHO Academy aims to become a center of excellence for learning science, where we connect as a service for the rest of the organization and the member states to create learning on all key aspects of public health and connecting them to the right science at the right moment in the right format. But we do not want to do this. No, we cannot do this alone. So the Academy also aims to become a catalyst, creating a network, an ecosystem to build lifelong learning, specifically where it is less functional. And we have also another aim is in many countries people struggle to set up these systems, so we would hope to create a framework of norms and standards that could help many settings to improve their own systems, and we will be very happy to create the toolboxes to further establish this. Well, who are we going to see as our target learners? First and foremost, healthcare workers. But not only all these millions of people that are there, but also looking together with the key stakeholders, ministries, health, but also of education, to see maybe some of the reforms that everybody is thinking of, maybe we can accomplish them. We've been hearing about task sharing as a key solution for some of these enormous gaps. The numbers are 9 million healthcare workers shortage in the world. We cannot just create that, fill that gap without any creative solutions. There also we hope to contribute. Decision makers in public health, not only the real high decision makers at the top, but all these hundreds of thousands of staff of Ministry of Health that are public health decision makers in offices that are much less comfortable than the offices most of us are used to. And these are really the people that are at the front line of decisions in case a next epidemic starts to arrive. And also the Academy wants to be the place where the whole learning and development for its own workforce will be hosted. Key is there is lifelong learning. Lifelong learning for healthcare work is very complex and has many components from education, exposure and experience. There we want to intervene and interact at all these different levels in a smart way through mentors, all different way of learning and specific creating communities of practice. For me, this is the biggest challenge, how we are going to create a capacity, a support for all the countries where this system needs to be further performant to bring that to scale. And I think if we could find that solution in a couple of years, we would truly have accomplished our mission. So what kind of solutions does the Academy bring? It's here called courses, but I think we can call it courses, learning programs, and other learning solutions. So on the highest part, you can see that the Academy wants to create a strong body of our own courses. But of course, the WHO did not wait for its Academy to start creating many learning programs. So step by step, we will become the house where all these learning programs can be very easily and efficiently accessed by all healthcare workers wherever. But again, we talked about partners, and I will come back to that later because I hope some of them are in the audience here. We really want to host also courses or programs created by anybody that wants to collaborate with us, either by hosting the courses directly or creating links to existing learning platforms. And of course, since the pandemic, there are so many learning platforms that have been created. So we hope that we can create some extra efficiency and access for people that are really looking for learning capacity and solutions. So to keep a bit of focus, as you see, our ambition is several hundreds of courses, but also want to focus on some specific priorities. Quite a lot of them can be routed directly to solutions for pandemic preparedness. One Health, there is no doubt that this is very important. So all of these six, we plan to create multi-year programs with lots of learning solutions and outreach actually into the field with partners, and hope also to find real energy and resources around them. So learning can not only be just online, but we can further develop blended learning with actual learning sessions in country, with creating an ever-growing force of efficient teachers where people are working. So One Health certainly, as we have learned, and the actual plan is that we co-create the strategy of learning of the quadripartite of WHO, WOHA, the FAO, and the UN environmental program. Nurses and midwifery, if we really want to make the world more resilient for the next pandemic, that's where we need to really create extra up-to-date skills and competencies. Healthy cities, we will work together with the Association of Healthy Cities of the WHO. Soon we'll move to a world where 50% of its population lives in cities, so solutions adapted to these environments, we were happy to contribute to that. Antimicrobial resistance, I think it's the ever-growing constant pandemic, foreseen to be one of the biggest negative health impact influences of factors of public health. Biomanufacturing, that's where we very directly would hope, we plan to collaborate with all actors to create capacity of vaccine production in Africa. And finally, I come back to the leadership in public health, decision makers, and all these peripheral offices of public health of ministries. There we really hope to contribute to better decision-making competences and skills. So what do we actually offer? I'm very happy to say that since 2 weeks, our campus is now actually live and open. From there, but also in many places, we want to create all the capacity to produce courses, to give distance learning, but also create seminars, face-to-face sessions in Lyon, in France. Our portfolio of very learner-oriented courses is going to continue to increase, and we specifically invest in a learning platform that is adapted to needs of healthcare workers where they are working, as you see, of course, with a very performant mobile component. Lastly, very specifically, as we are a component of the WHO, we also feel it's our responsibility to strengthen standards and norms. And everybody you talk to in the world of learning for healthcare workers, there is a void there. Governments in the global south are struggling to set up systems that are really efficient in continuous learning, and we are happy to help them to support this in these endeavors. Partnerships, I come back to it again. So any university or learning institute in the room or outside are very happy to connect to all of you because the challenge is enormous, and we are very, very happy to be a catalyst in creating this. I want to stop by creating a small spotlight on the last month of the year. In December, we will organize in a couple of events, but specifically on December 17, our formal opening of the Academy in Lyon. Thanks, everybody.
So thank you very much for these excellent talks, and we have time for discussion. So I ask the speakers to take a seat at the tables. And before we potentially open the discussion to the audience, I hope we have some more time. I'm sure we are still in the room afterwards. So if you have specific question, you're welcome to come directly to us. So yeah, I think we had very interesting talks about interdisciplinary aspects. So after the introductory talk by Gülşah, we learned about hidden threats behind the pandemic from Veral and Carmen about cardiovascular disease, long COVID. We had two interesting talks about mental health with Anke introducing in the Respond Network, and Acep into the challenges Africa has faced in managing pandemic situations, and Bart concluded with a very important academy which is now starting in Lyon. So we learned a lot, and it is a fact that often interdisciplinary aspects work hand in hand. So, for example, if you prevent infection, you will also prevent the hidden threats behind it. So if you have a vaccination, then you can prevent long COVID and cardiovascular disease. But it may also be different with mental health. For example, infection control measures like school closures increase mental health burden. So you always have to balance the different interdisciplinary aspects. So my first question I would go to Bart, Anke, and Meral about how to bring the interdisciplinary aspects on the agenda. How can we bring that really in the situation that it is faced by policymakers, for example, that not only the preventive antiviral infection control measures are important, or but also the other aspects. Bart, may you start, perhaps?
Yes. Yeah, thank you. Well, I will take a modest stance to speak for the entire organization, the WHO, which is not my real role. Well, I think the WHO, in first and foremost, has a coordinating role and bringing at times of crisis or pre-crisis all stakeholders together at different levels, globally, in the regions, but also in countries. I think that's one of the strengths of the organization. And secondly, obviously, it is confirming the norms and around science, and taking away some of the doubts, and hopefully creating the trustful messages to the audience. From the learning perspective and from the academy, that we hope, of course, that we will, when it comes again to another dramatic situation, to be really ready and capable to deliver real on-time solutions for learning, to upskill and to, because that's the whole thing. Science and information move so fast, and then we need to bring it to where it belongs, where the action is happening. It's very easy to write guidelines and create new science and publish them in worldwide articles, but the impact is happening at the front line. And I think that's where this level of distribution of information in mobile and online formats, in a trustful format where people are connected. Hopefully in 3 years' time, we will have 5 or 10 million healthcare workers that are automatically on our platform, and that will be then a powerful tool to transmit trustful information.
Yeah, thank you very much. Meral, maybe you can comment on the role of the pharmaceutical industry in addressing these different topics.
Yes, exactly. So I guess all of these connect to each other, right? So the role of the pharmaceutical industry would be to produce the vaccines, to produce the best possible vaccines with the best available technologies, or invest also in science, I would say, for developing even better technologies, if possible, to be able to come up with the vaccines or antivirals, also depending on what pharmaceutical we are talking about, and be transparent and have closer relationship, I would say, with the scientific world and also the regulatories, so that the vaccines or the antivirals are made possible in the amount of the time that is required, and also be transparent and really have robust data and communicate openly the effectiveness of the vaccines and tell what it actually means. I think there is something like a missing gap. I come from public health and academics. So when I joined the companies and I saw like when you're communicating the effectiveness, if you set the bar too high, the expectations are too high. And we lived this during the COVID-19 pandemic also, right? So we said that the vaccine is 94% effective. And then people took the vaccine and then they got the infection. So that was not really communicated very well. I mean, this is the role of the pharmaceuticals also, to communicate with all the stakeholders. What does this data really mean? And how did I obtain this data? How is my methodology? Is it robust enough? And we also need scientists to really deeply analyze all the publications about all these vaccines so that we make sure that we produce a quality product and then that is available in time when it is needed.
Mm-hmm. Thank you. And my last question goes to Anke about the role of a Respond network. Is it being continued? You can just talk.
I just talk.
Yeah.
Yes, in Respond, it's important to what we do at the moment is build a platform with all packages, the interventions that I showed today, and the effectiveness of those interventions. Build that in a platform and get that to the communities, the peoples that are in need. And that is not only in terms of pandemics, but broader in societal crisis. For example, we are now doing really implementation work in the bordering countries of Ukraine, for example, with these packages to train people, peers in those areas. And these kind of networks, they keep existing because, we have several WHO collaborating partners in several countries that also focus on the groups and people that are in need of, most support. Or so I think we can do more in that, but we are working on that as well.
Yeah, great. Anke, so we open the discussion or the question round. If you have any questions, where's a mic? Here's your first hand. Okay, please stand up and introduce yourself.
Thank you very much for this session. My name is Masika. I work for the World Federation for Animals based in the US, but I'm based in Nairobi. My question is to Bart. I'm very happy to hear about the WHO Academy, and we work very closely with WHO, but my question is, we know where the need is highest. We know where the vulnerability is highest. Why do we have a WHO Academy in France when the need is clearly not higher in France? Clearly with the attendance in this meeting, not just in this room, we have very few representation from the Global South. And we cannot continue having meetings in Europe when the Global South do not have access to these meetings because of visa restrictions, financial restrictions, and many, many other things. So why, of all things, have a WHO Academy in France?
Very logic and a very good question, because maybe I didn't make it clear enough, but the WHO Academy has a clear priority focus on low and middle income countries. And that's where we would like to be performant, that's where we'd like to have our impact. Why in France? Well, there is a very simple reason for that, is that the French government has been the main sponsor and has taken the initiative together with the WHO to establish this. And we've started the work in France. But the idea is really that most of our investment goes on the online platform. Our continuous and growing investment will be on actual learning, first accessible on all kinds of platforms, and actually happening in the health workforce spaces where people live, in hospitals and in health centers, where all health care workers are working. But I fully understand the question. The optics are clear. It's a strong unit created in France, but our action will be actually in the hospitals and in the health centers, Africa, Asia, Latin America.
So that means that most offers are digital offers. So you can use it in Africa and make the training.
Not only. Of course, if we want to reach millions of healthcare workers, digital is a very handy, and we're very happy that it becomes performant now in so many places of the world. But our plan is also to create actual face-to-face presential learning sessions in healthcare settings throughout the world, with a primary focus on low and middle income countries. Mm-hmm. Furthermore, while we really designed our learning platform for that, it can actually support the creation of very performant peer-to-peer networks and communities of practice. And I think that power will, only in a couple of years' time, it will be really creating an interaction. And then the center will not be in Lyon anymore, but the center will be completely spread over the whole world.
Yeah. Okay, thank you, Bart. We have time for one additional question. If someone has a question. Yeah, here's another one.
Hi, my name is Prathama. I work in Ministry of Health and Government of Canada. My question is to Marcel, if I have got the pronunciation correct.
Meral, it's
Meral,
okay.
Sorry about that. So I'm wondering, what are your thoughts on RSV, since we talked about influenza and COVID-19, and if your lab plans to do some research, mostly RCT related to RSV?
Yeah, thank you for the question. Yes, I mean, I think RSV has been already recognized as one of the main viruses that is especially impactful, having impact in the younger age groups and the older age groups. And many pharmaceutical companies, including Sanofi, also are working on different types of preventions. At the moment, the monoclonal antibodies are available and they are quite effective and they are being used. And there are also vaccines for the older populations. Yes, so the work is ongoing, and hopefully there will be effective vaccines also for the older populations and enough vaccines. We know, and I mean, I guess whoever is virologist, I'm a virologist and I worked in the lab. So when I was working, of course, I was working on influenza first. And then when these multiplex PCRs became available, and I think I was the first one to be shocked. I'm like, okay, I thought it was only influenza, but then there are other viruses out there that actually could have devastating impact on, on people at the individual level and also at the public health level. I think what makes influenza the queen, in my opinion, is because this virus, we have variety, too many influenza viruses, and it has a pandemic potential. And we thought that was the only pandemic potential, but then now we have the coronaviruses. Any virus that has animal reservoir has that potential, but I guess the RSV would not fall into that category of pandemic preparedness. But it is a seasonal virus, and it is exactly, yes. So hopefully soon we will have enough means of prevention and also treatment available for the RSV also.
Okay, so we are at the end of the session, unfortunately, but you can come to us and discuss with us. And on behalf of Gülşah Gabriel, I thank all the speakers, all the discussants, and all you for joining the session. And we wish you all an interesting World Health Summit and a safe stay in Berlin.